Medurstand-Understanding Medicine.
Professor Aziz-ur-Rehman here. In the last video, we discussed the conduction system and I explained to you the function of various parts of conduction system. And in this module, we will discuss some of the abnormalities related to the conduction system. So this is our curriculum. Last time introduction of conduction system was done, and this time we are going to take up sinus node abnormalities. Of course, we will take up other abnormalities in other videos. Now, this is the revision of what we already discussed. I will not go into the details. I hope you remember all we discussed in the last video. And this slide also showed you the problems related to the SA node. The same thing in this video we are going to explain in slight more detail. And the abnormalities you could see in SA node disease is sinus bradycardia. Sinus bradycardia may be physiological and may be pathological. If it is due to some pathology, that pathology may be related to the heart itself, maybe the effect of some medication, and maybe the effect of some systemic disease, some brain disease. So sinus bradycardia can be actually a serious condition, but maybe just normal physiological state, and sometimes seen in professional athletes. Professional athletes typically have low heart rate, resting heart rate. I have not included tachycardia in the sinus node abnormalities because that I'm going to cover in a series of videos on tachyarrhythmias. These days we're covering bradyarrhythmias. Then there's a condition called sinus arrhythmia and sinus block, sinus arrest, and sick sinus syndrome. All these conditions we are going to briefly discuss in this video. Now, I will let you figure out what is this ECG. It is not complete 12-lead ECG, just one strip. Now, you all know whenever we analyze rhythm, we just need one strip, but we need a continuous strip. Most ECG machines, they record 12 leads, they record 3 or 4 cardiac cycles, and then they change the lead automatically. But on the bottom of the paper, you will find one continuous strip without any interruption. And if you do not have automatic machine, probably after doing 12 lead ECG recording, you will need to record one long strip, and that long strip is either limb 2 or precordial V2. Why these leads? Because for rhythm analysis, we need to see both P wave and QRS. In some leads, P wave may not be visible or not visible clearly because of the location of these leads and the location of SA node. P wave is best seen in either limb 2 or V2. So I think it is best to analyze one of these two leads, and if you have some other lead but P wave is seen clearly, then of course you can see that. So for rhythm analysis, you be able to see both P wave and QRS complex. So when we talk about the heart rate, we actually talk about the P wave. Of course, the QRS complex, the number of QRS complex in normal heart would be the same because every P wave is conducted to the ventricle as QRS complex. So we have as many P waves as QRS complexes, but heart rate is typically calculated from the P wave, the sinus rate. Ventricular rate may be calculated from the R waves. Now let's see. Mostly atrial rate and ventricular rates are equal, so it doesn't really matter which wave you use. Now, what do you see about this ECG? This one. This is, I think, the drawing. for the purpose of clarity. It is sinus bradycardia. What is sinus bradycardia? When rhythm is sinus but heart rate is less than 60 beats per minute. So these are the two criteria. Sinus rhythm, how do we say this is sinus rhythm? We have atrial depolarization and we have QRS complexes and we have normal PR interval. So it appears that every current is made in the SA node and after certain AV nodal delay is conducted into the ventricles, and that is what sinus rhythm is. So this is sinus rhythm, but heart rate is less than 60 beats per minute. Remember, this 60 is purely arbitrary. A person with heart rate of 58 may be absolutely super healthy and somebody with heart rate of 65 may be sick. So this is purely arbitrary. In this case, I made the calculation, and you in the first, I think first or second module on ECG, we learned how to calculate heart rate. If somebody has stable rhythm, then you divide 1500 by 28. What is 28 in this case? It is actually we divide 1500 by number of small squares between two adjacent R waves. In this case, now it is best to start counting from a complex which is uh, like this one. I'm not this one, which coincides with a line because it is easier to count squares. So if you start counting from here, 1, 2, 3, 4, 5. So 5 complete boxes, that makes 5 into 5, 25, and 3 additional. So that makes 28. So 28, 1500 has to be divided by 28. That will give us the heart rate. That is 54 beats per minute. So it is bradycardia. Now let's take another slide now. Do you see any problem here? This is 12 lead ECG. We don't need to go to these because we're not looking for any morphological abnormality. Just see the rhythm strip. This is the rhythm strip. What do you say? It is sinus rhythm because every QRS complex is preceded by P wave and we have as many QRSs as P waves. So this is sinus rhythm. QRSs are also narrow, P wave is also normal morphology, sinus rhythm, but heart rate is less. I have just made the calculation. 1500 divided by 37 is 41. So there is actually severe bradycardia. Now, by the way, I explained earlier, but here also, do you know where this figure of 1500 come from? This comes from the fact that normal ECG is recorded at 25 millimeter per second. If that is the case, one we have to, there are actually 5 small squares makes 1 second. Since we have to calculate heart rate per minute, so 5 large squares is equal to 25 small squares, and we have to count it for 1 minute. So we have to make the appropriate calculation to get this figure of 1500. 1500 is actually 25 multiplied by 60 because 25 small squares in 1 second and we have 60 seconds in a minute. So 60 multiplied by 25 comes to be 1500. So this is how we calculate heart rate. So this is a case of sinus bradycardia. How about this one? In the first glance, it is certainly not bradycardia. You see, it is not bradycardia. What is it? For the rhythm, we see the continuous strip, which is this one, limb lead 2, continuous. If you scan this lead from this side to this one, one thing you should immediately appreciate that RRs are not regular. Okay, so there may be some arrhythmia. RR is not regular, but you remember in some cases, some variation in RR is possible despite having normal sinus rhythm. Now, if you see again, there is a kind of pattern, this wave-like pattern. This symbolizes that heart rate accelerates, decelerates, accelerates, decelerates, and accelerates. So there is a kind of pattern in this arrhythmia also. And this corresponds, the cycle is about 16 per minute. What other cycle in the body is 16 per minute is our respiratory. Respiratory cycle is approximately 15, 16 per minute. So could it be sinus arrhythmia? Heart rate getting accelerated during inspiration and decelerated during expiration, inspiration, expiration? Well, that is definitely a possibility. It is actually the case. Sinus arrhythmia. If this variation is less than 10%, that means the fastest heart rate here and the slowest heart rate here are not different than more than 10%, it would be considered normal. And if the change in this difference is more than 10%, it would be called sinus arrhythmia. Sinus arrhythmia may be relatively benign condition in some people, especially young people, or it could indicate some problem, that problem related to the heart or body or mind. So that is actually beyond the scope of this lecture or this video. Here you should be able to identify sinus arrhythmia. I think this variation in heart rate you would immediately identify, but then you should concentrate if there is pattern, if there is cyclical pattern. If there is a cyclical pattern, then you will have to make the judgment if this difference is less than 10% or more than 10%. How do we do that? We calculate heart rate here, we calculate heart rate here, and then we may find out the difference. So this is the sinus rhythm. Sinus rhythm, because we have nice P waves, we have nice QRS complexes. There is one-to-one faithful relationship between P and QRS. So it is sinus rhythm. QRSs are also not broad sinus rhythm. And the second thing is heart rate variation, sinus rate variation more than 10%. So let's see if we can demonstrate that. I calculated heart rate here where there was bradycardic spell, and the heart rate here was 60 because number of small squares between two RR was 25. And if you can confirm it, 1, 2, 3, 4. 1, 2, 3, 4. Sorry, it is 4. That means actually I think I made the calculation here. So you can do it. If you pause the video here, you can confirm it. Heart rate at this level is 60 per minute and at this level is 94 per minute. I think here that number of small scale is 20. Here the number of small scale is perhaps 14. So the heart rate is 60 and 90 and difference 94 minus 60 divided by 94 multiplied by 100 is actually much more, I think 34%. So that is sinus arrhythmia. What do you see here? This is again the same tachycardia, bradycardia, tachycardia, bradycardia. This is again sinus arrhythmia. You can confirm the variation more than 10%. So this was about sinus arrhythmias. Now we will take up some other abnormalities of SA node. So this is actually highlighted by magnifying it. Sinus arrhythmia. Now, if you remember the second slide in this video, we could have sinus bradycardia, sinus arrhythmia, but then there could be another problem. Here you see this just one strip, P wave QRS complex, normal PR2, and this is limb lead V, this is precordial V2. So this is sinus complex, sinus complex, sinus complex. But you suddenly notice that there is no P wave, no QRS complex. So entire PQRS, entire electrical cardiac cycle is dropped, and then everything becomes normal again after some pause. So this could be a case of sinus arrest. That means a sinus node just didn't produce current for one cycle, or it could be sinus block. That means sinus node did produce current, but it did not come to the atrial ventricle. Now please note down, SA node activity does not reflect in ECG. Only when it depolarizes atrium, it produces P wave, and when the same current goes into the ventricle, it produces ventricular depolarization. Sinus node activity within the SA node does not produce any ECG change. So we don't know whether sinus node activity occurred and didn't come out, or it did not occur. But there is a way to find out. I'll show you very shortly. This is a bar reflecting 2 pp. So this is 1 pp, this is the second pp. Okay, so this difference from this to this is equal to 2 pp intervals. Now if you do the same exercise here, from this P wave to this P wave, and presumably there was a P wave here, or there was to be, and that I have labeled as P in bracket, or you can call it P naught. So this difference, so if this bar and this bar, then we have to see if they are equal or not. You can check it visually, but I have demonstrated in another way which should be more convincing. See, this is this one, and we move this one to here, it is equal. Okay, so 2 pp interval and the interval between two P waves with one absent PQRS complex is the same. That means perhaps the electrical activity did occur, but it just did not come out of the SA node. Okay, that is why, because the next beat, because SA node activity was not actually disturbed, the next beat came on its expected time. So that is a clue. When next P wave, next atrial depolarization came on its expected time, we assume that this activity, actually SA node, did occur but stayed within the SA node, did not come out. That is why the next one came out in its time. Although that can occur just purely as a coincidence, but I think we should assume this is a case of sinus block. Sinus block, if I have to define, it's a condition where sinus nodal activity occurred within the node, but it didn't come out of SA node, so it did not depolarize atrium and it did not depolarize ventricle. If this condition had persisted, then some pacemaker would take over. But since in the next cycle it resumed, other pacemakers, the potential pacemakers in the body, they were kept suppressed. So the definition of as sinus block is criteria. First, you have to demonstrate that the basic rhythm is sinus. Here, basic rhythm is sinus, and then you see 1 PQRST, complete electrical cycle is dropped, right? PQRS is completely dropped. And the third criteria is P naught P, this one. From this P, naught P means there was expected P wave here that did not appear. So P naught P is equivalent to 2 pp interval. Actually, I have written n, it could be 2. In this case, it is 2, but theoretically, this QRS complex could come after dropping 2 P waves. So in that case, this number might be 3. Of course, If it is more than 3, then before sinus node will retake the rhythm, perhaps some pacemaker will take it over. But I think theoretically you could have this number 2 or 3. But this P not P has to be an integral multiple of any one number that is reflected here. Okay, so this is sinus block. Little fancy, but it's interesting. Don't you think so? So sinus nodal block. Things are slightly different. If you go this way, actually this is the step. If you go, just imagine going this way. P, 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 and then one PQRS complex is dropped. Actually, you have to come from this way, but since the step is shorter on this side, so I just, for the sake of exercise, coming from this side. So one PQRS complex is dropped here also, just like we saw in the last ECG. But let's do the analysis like we did in the last ECG. This is 2 pp interval. Okay, this is P wave, this is P wave, and this is P wave. So this interval from this bar represent interval equivalent to 2 pp cycles. This one, if you take the same example here, this P to this P, 1 PQRS is dropped here. Now visually you can say that they are different. They are not the same length, but we are going to demonstrate formally. There was an example I think it couldn't display, but you can actually visually see that this 2 pp interval is different than 2 into P naught P. So the criteria is basic sinus rhythm, 1 PQRST dropped, but this P naught P is not equivalent to any number of PP intervals. Why? Because in this case, sinus node actually stopped functioning. There was no electrical activity within the SA node. Something happened and SA node just didn't depolarize, didn't produce current. But it resumed. But it does not have to resume exactly when next P wave was due or when next depolarization was due. It could resume anytime. So it did resume, and it resumed before the next P was expected, next electrical depolarization was expected. So that is why this 2 P naught P is less than 2 PP. So this is sinus arrest. Sometime in the same strip we see sinus arrest and sinus block. That means that the SA node is unstable. So this is how I show it. Okay, so I think the sequence of this animation was wrong, but this is how now I show the actual principle that 2 pp is more than 2 naught p. Thank you very much. This is Professor Aziz-ur-Rehman, and I hope you enjoyed my presentation. I covered SA node abnormalities. We started with sinus bradycardia, we discussed sinus arrhythmia, and we also covered sinus arrest and sinus block. I hope you continue to enjoy my videos. I really look forward to see you in my next one, which is going to be on some other ECG abnormality. Thank you very much for joining.